Assalamu alaikum. Our next session will be an interactive session. We'd like from the audience and the participants to go to the link so they can interact with the voting for the result of the questions from the presenter. The first speaker will be Dr. RAED. He is assistant professor in Hospital of University of Cuba. He graduated from Madina Master in 2006. He's a gastroenterologist. This case will be an interactive case discussions. So please from the participant to go to the link from now in their phone. Welcome to the RAED.
Thank you, Dr. Mahdi. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه المنتجبين. First of all, really, I'd like to thank the organizing committee for giving me this great honor to present in this very interesting and important meeting, especially to Dr. Ahmed, really, who do a great job here in organizing this meeting, and also extend my thank to ABFI for their effort. Now I think this is time to try to transfer our knowledge into practice. We learned a lot during those 2 days. Yesterday from Dr. Nahla and today Dr. Shakir. They're presenting a lot of data on how to approach patient with Crohn's disease and how to apply, treat, to target, and to do the time-bound management. As you know, Crohn's disease really it's a spectrum of disease. Patient, they are not really the same. One Crohn's disease is different from others. So we cannot really apply all the management to all the same management to every patient. We have to choose a prognostic factor in each patient in order to select the most appropriate treatment. We cannot start biological therapy early in every patient. It's not cost effective, as well as you know from manipulation-based study. Roughly half patients of Crohn's disease they have mild course and they will not require biological therapy. So the aim of this presentation is to discuss really how to select the prognostic factor in order to help us as a gastroenterologist to decide the treatment. Those are really a real case scenario. So I will start with this lady, Lee. And what to do here, I will present the data and we'll present certain element in this patient history. And I will ask you as an expert to tell us what do you think. If this really factor is important, it will help you to stratify your patient into high risk or low risk, or it has nothing to do with stratifying your patient. So we'll go over this case. This lady Lee, she is 19-year-old female. She is from Canada and who's studying biological science at university. She is non-smoker and has no relevant traveling history. So these are brief data. So the first factor, as you can see here, there are many factors. I will ask you to choose if those factors are non-predictor or predictor to worse prognosis or predictor to a good prognosis. So we'll start first with the age. And from your website, I think you can vote for it. So for the age, we'll start. The age for this lady, as you can see, she is 19-year-old at the diagnosis. So what do you think? Age, is it important? Give a favorable outcome, 19-year-old, or poor outcome, or non-predictor? Wow, this is really. في بعض المتردد. This is final? Final, okay. So we have 73% saying that age less than 19 is a poor outcome, and 27% saying that it's favorable outcome. Okay. So we'll go with the vote. Of course, we know the answers at the end of this presentation. We'll choose the age according to your vote into poor outcome. Great. So the next element in her history, She has no evidence of extra-intestinal manifestations. So she has no evidence of extra-intestinal manifestation. So what do you think about this? This shows a favorable outcome, poor outcome, or non-predictor. So you can vote, please. So it's great. Okay, 91% said that it has favorable outcome. We'll go here. Okay, third element, Miss Lee, family history. She has no family history of inflammatory bowel disease. So no family history of, what do you think about family history in patients with inflammatory bowel disease Crohn? Would it affect your, or would it stratify your patient to high risk or low risk, or has nothing to do with as a predictor? So please can you vote for that? Okay, here we can say there is a 50-50 between not prognostic or favorable outcome, but more maybe toward 50% toward not. Okay. So what do you think?
Also, you should pick the highest figure.
But if highest is none, صح? Okay. What do you think? Chairman, you can vote for. So I think your voice is for two voices, is it? So we'll leave it as non-predictor. Okay, good. What do you think about education? Miss Lee, her education, she is, as you know, she's a university student, so she considered to be educated. So whether education considered a part of prognosis will affect stratifying with the risk of your patient, will alter your management plan? So she is a high education, high level. So favorable outcome. Okay, we'll see. So we'll choose for education, that will choose favorable outcome. Perfect. Lifestyle. From her lifestyle, she is a non-smoker. So patient, inflammatory bowel disease, Crohn, and she is non-smoker. What do you think? Is this good? Okay, it's 100%. It's an amazing vote. Nice. So we go for lifestyle. This is a favorable outcome, non-smoking. Okay, so she had endoscopy in her initial presentation, and the endoscopy, it shows two lesions, one of the sigmoid colon and one of them in the transverse colon. So her colonoscopy shows epithelium to be ulcerated in the transverse colon and sigmoid colon. Small anal fissure is present, and the ileocecal valve and the distal ileum both appear normal. So it's mainly large bowel disease, but the description of ulcer, as you can see here, it's a deep ulcer in the sigmoid colon, and the other one, transverse colon, also multiple deep ulceration, and there is an anal fissure. But the small bowel looks normal. So based on this findings or presentation, what do you think based on the colonoscopy? Would it be a favorable outcome, poor outcome, or non-predictor? Colonoscopy shows lesions only in the colon, deep ulcer in the colon, but normal small bowel. Excellent. So we have majority vote toward poor outcome. We'll take endoscopy into the poor outcome. Great. Histology. So as usual, we get the biopsy from this lesion, and it shows that deep ulceration from the histopathology present in the mucosa and submucosa, dense inflammatory infiltrate consisting of chronic inflammatory cells in the mucosa and submucosa. No granuloma seen. Rectal mucosa has mild inflammatory cell infiltrate only with no ulceration. Appearance is consistent with inflammatory bowel disease and favor Crohn's disease. So based on that histological findings, there is anything to support poor outcome or favorable outcome based on histology, or it has nothing to do with it, or cannot predict? Histopathology in Crohn's disease. Excellent. Yeah, no wonder there is expertise over the field. So we'll go histopathology. We'll leave it here, non-predictor. Okay, imaging. So she had MRE as part of her evaluation or the investigation, and the picture of MRE actually consistent with what we found in colonoscopy. Revealed extensive deep ulceration of the colon with patchy involvement. The sigmoid colon and transverse colon also appear to be involved. And here the small bowel also was normal. This is based on MRE. So giving this picture from radiological evaluations, what do you think about radiology here or imaging? Would it help to stratify also your patient into poor outcome or favorable outcomes? MRE showed deep ulcerations in the transverse colon and the sigmoid colon. وقف 50% favorable outcome. MRE showed the deep ulcerations. Okay, so 50% safe. What do you think, Dr. Mahdi? Favorable. Favorable. Okay, we'll go to favorable outcome. Okay, so in order to assess the disease activity, we use the, as you know, the Harvey, the Blatchford score. Here, her score actually was showing moderate risk, or maybe moderate stratification. Her patient general well-being very poor, and abdominal pain for the previous day was moderate. Number of liquid stool per day was 5, so she scored 5. There is no abdominal mass, and she has only from the complication anal fissure and aphthous ulcer. So total score of a 12. So according to the rating here, as you know, from Harvey Bradshaw score, 12 indication of moderate disease. So according to this score, she has moderate disease. So for using this score, what do you think is it a good marker for prognosis? It can label your patient whether they have high risk or low risk region. So you can tell us, please, from this. Sorry, on this. Okay, so based on that score, which has no non-predictor, favorable outcome or poor outcome of a 12. Poor outcome, 17. Okay. We'll go with the voting into poor outcome. And last element of those factors is a treatment. So as for her initial presentation, she was started on systemic prednisone prescribed for the patient on the first visit. So she has systemic steroid started. This is her first presentation. So this information, would it help you to stratify your patient and to have favorable outcome or poor or non-predictor starting systemic steroid? Okay. So yeah, we'll go. Majority say that this is an indication of poor outcome. We'll go to poor outcome. Perfect. So again, let us make sure about our answer here, or your voting. The non-predictor is family history and histology. Favorable outcome, no extraintestinal manifestation. She has university or high class education. Lifestyle, there is no, she's non-smoker, and there is an MRE findings of deep ulcer in the transverse and the sigmoid colon. So those are favorable outcome based on your voting. Poor outcome, young age group, deep ulcer and endoscopy, and high score, as well as starting on steroid. So based on those evaluation, what do you think overall stratifying your patient? Would you consider this patient as favorable outcome or poor outcome overall evaluation now, based on all those factors? Whether she has 4, you choose already 4 element: age, endoscopy, HPI, and treatment. So she will be poor or favorable outcome. Okay, so overall poor outcome. Okay, excellent, poor outcome. Good. So now let us see what's the correct answer. Okay, so I'm going to present the correct answer according to the expertise recommendations or evidence available. For the age, it's correct, agree. Age less than 16 or age less than 14 considered to be really an indication of high risk. So any patient with inflammatory bowel disease diagnosed at age less than 40 considered to have really a high risk for complications within the 5 years from the diagnosis. Her age here is 19, so this is considered to be a poor prognostic factor. Second thing, absence of extraintestinal manifestation. Yes, this is really a good prognostic and put your patient into a good, favorable future, because presence of extraintestinal manifestation really make her at higher risk. Family history. Most of the data really show that family history is not affecting really the prognosis. But there are data supporting that if there is one member of family has a Crohn's disease, there are higher chance of surgical complication in this patient, as well as higher chance of intestinal failure than a sporadic case. But this data is really not strong, so they are not considered as a prognostic. Education, actually, they said that education can improve the compliance of the patient, but it is not really considered as a factor to stratify your patient to high risk or lower risk. It can help to your patient to be more compliant, but actually it's not really a factor to stratify your patient to whether it's higher or low risk patient. So this is really an incorrect answer. It should be non-affecting the outcome. Lifestyle, totally agree, or the smoking. Absence of smoking or presence of smoking put the patient into a complication of the disease. Also, they are at higher risk of dose escalation, higher risk of surgical complication, and higher risk also of surgery. So smoking is one of the really poor prognostic factor. Endoscopy here, presence of deep ulcers in the colon considered to be really a high risk for developing complications, as well as small bowel lesions. So here, this patient, she has a deep ulcer in the colon, and this considered to be a high risk or one of the worst poor outcomes. So that your correct here is correct. Histology, actually, it is non-prognostic, as said correctly. It can help to diagnose the case, but will not really put your patient into higher risk or low risk, even though now there is a data saying that the histopathology and early diagnosis of inflammatory bowel disease can stratify your patient into either penetrating inflammatory or structuring disease, but wouldn't affect the prognosis. Regarding imaging, the same thing applying to endoscopy, actually, it's applied to imaging. So if a patient with imaging showing that there is a deep ulcerations or the colon and sigmoid, they are considering really as a prognostic factor in patient with inflammatory bowel disease. So imaging, yes, it will affect, will give you really a favorable or poor outcome. So here the answer should be really yes, it should be one of the poor outcome. Regarding the score, the score can help to stratify or to tell you the activity of the current presentation. But the studies show that it wouldn't really affect or wouldn't put your patient into higher risk of complication or not. Only it's important for the active presentation rather than as a factor for worse prognosis. And the same applies for Crohn's disease activity index. The treatment, the answer really is correct, that starting steroid in the first presentation, this is really a poor outcome, and this justify your patient that will run most likely complication in the future. So here, according to the scenario for this patient, the presence of those four factors, totally agree, it put your patient into a poor outcome and high risk Crohn's disease patient. So what happened to the real scenario in this case? After starting her steroid and follow up after 12 weeks, patient is still really actually symptomatic. They cannot taper her steroid, and azathioprine was started. Again, after 12 weeks, she failed to be controlled, and anti-TNF was started, and she was achieving really a good remission after 1 year. So this is regarding this case for prognosis. If you have any questions or
There's one more question.
I think.
Would you advise to use this score for your patient assessment? So
Which one?
Would
I think we done.
Would you use this score system for your assessment to your patient as a voting from the audience?
Which score?
This is score system.
Yeah. For me.
I mean, would you
Okay.
utilize
This
this application?
So 100% yes. Okay. This is great. But here I cannot really control it from the screen. I think that's it. This is the end. Huh? Okay. Thank you.